Welcome back, everyone. This session is genetic screening and testing. I'm Kelly Trout. I'm a registered nurse and the Director of Research and Medical Advocacy for the International WAGR Syndrome Association. I'm also the patient advocate for the Renal Tumors Committee of the Children's Oncology Group, and I'm the mother of a long-term survivor of syndromic Wilms tumor. It's an honor to be here today and a great honor to introduce Joyce Turner, our speaker for this session. Joyce is a genetic counselor with more than 25 years of experience. She is co-director of the Pediatric Cancer Genetics Program at Children's National Hospital and assistant clinical professor of pediatrics at George Washington University Medical Center. Joyce, we are very grateful to have you with us here today.
Thank you so much for inviting me, and it's great that everyone here could join. I want to thank you for being here and thank the organizers for having me here to speak with you today. And thank you, Kelly, for the warm introductions. Today, I was asked to talk to you about genetic counseling and genetic testing for Wilms tumor predisposition. Next slide. So what I was hoping to focus on today is to describe what actually a genetic counselor is and does for those of you who haven't met with one before. I'd like to define some basic genetic terms so we can all understand some of those medical terms, genetic medical terms, why and how one might undergo or have some genetic testing, and what are some Wilms tumor predisposition red flags that might be an indicator that someone might have a predisposition syndrome. We'll also focus on who to test and what sort of testing is available, what's coming down the pike, as well as what is the difference between genetic testing and screening, and how to get genetic counseling and testing if no one's talked to you about it before. Next slide. So what is a genetic counselor? Next slide. So basically, I and other genetic counselors receive specialized training. We get a specialized degree, master's degree, and we actually do have to sit for the boards, so I am boarded. We also will, on a state-by-state basis, genetic counselors have to be licensed, so I'm also licensed in 2 states. And when I meet with a family or a patient for genetic counseling, some of the things that I do include reviewing their personal medical history, their family's medical histories, and based on the information that I get, based on, for example, what type of tumor we're dealing with, what's the age at diagnosis, what's the family history, I will assess whether or not I think that this is more likely to be, let's say, a Wilms tumor due to an underlying genetic cause, or is it more likely to be a sporadic occurrence and not related to a genetic syndrome? So I will meet with families and we'll discuss what the differential diagnosis might be. We'll discuss what the syndromes are, and basically educate families. We will explore the risks and benefits of genetic testing and what might that mean in terms of the outcomes. I help to facilitate the actual testing process using potentially different tissue types. And of course, meet with the family to go over the test results. If they're positive, discuss what sort of surveillance or plan of action we need to put in motion. And of course, work very closely with the treating oncologist as well as other specialists to help facilitate their care. Next slide. So let's define some of our terms so we're all speaking the same language. Next slide. All right, some people might ask, well, what's the difference between chromosomes and genes? So this is a picture of our chromosomes. They go from biggest to smallest. So number 1 is the biggest and number 22 is the smallest. And if you're a male, you have an X and a Y chromosome. And if you're a female, you have 2 X chromosomes. And our chromosomes are basically our home to our genes. All along the length of our chromosomes are our genes. We get half of our chromosomes and half of our genes from our mom, and half of our chromosomes and half of our genes from our dad. So we basically have 2 of every chromosome and 2 of every gene. Next slide. If you look at our chromosomes more carefully, they look like these very tightly wound structures, much like an old-fashioned telephone cord or a slinky. And if you unwind them, well, first of all, I should say again, those genes lie all along the chromosomes. And if you unwind them very carefully, it'll look like a twisted ladder, with those rungs of the ladder being the genetic code. So you see these A, C, T, and G. These are referred to as nucleotides. How these different compounds are lined up in a row is basically the spelling of our genes. Next slide. So you can envision that much like a recipe is a set of instructions to, let's say, tell us how to bake some cookies. Our genes are also the set of instructions that tell us how to make a protein, and those proteins have a very specific job in the cell, one being controlling the cell cycle. It's very highly regulated. So you can imagine that if you have a typo in a recipe, much like, let's say, adding a cup of salt to your cookies as opposed to 1 teaspoon, it's very similar to our genes. If you have an alteration in the spelling of our gene, we very well might make a protein that's not working correctly or at all. Next slide. So let's talk a little bit about the differences between germline and somatic, because I get this all the time. A lot of people will come to me and say, well, my doctor already ordered genetic testing. And there are different types of genetic testing. There's germline testing, and then there's somatic testing. And there are changes in genes called variants that we can find in the germline, and there are changes in genes that we can find in a tumor, and that would be a somatic gene change. So, for example, with a germline gene change, that gene change could very well be in the sperm or egg that goes into our being, and therefore the developing embryo or fetus has that gene change in all the cells of the body, and therefore the resulting person has that gene change in all the cells of the body, and that person will produce eggs or sperm that would have that alteration as well. So you can think of germline as meaning all the cells of your body, and that's compared to somatic, where you can have a gene change that you acquire at some point in your life. That gene change is not in the sperm, it's not in the egg that goes into someone's being. It can be acquired during embryogenesis or when the baby's developing, but doesn't need to be. It could also occur just by going about your daily lives in some part of the body. So it's very localized. It's in, let's say, a tumor or a cell that results into a tumor in, let's say, the shoulder. But that gene change is not in all the cells of the body, and it's not in the eggs or the sperm that one produces. So that's kind of what we mean when we refer to germline, meaning all the cells of the body, versus somatic, meaning just, let's say, in this situation, the cells of a Wilms tumor. Next slide. So again, somatic is more of a local effect. You can have an alteration in a group of cells in a part of the body that, let's say in this example, only affects the foot. It's a local effect. Very much like the gentleman who that's on the screen that has the white forelock, white colored hair. That is due to a somatic change. It only affected a portion of his hair cells and his hair, not the entirety of his body. Whereas you could have a change in the germline that affects all the cells of the body and might, instead of just resulting in a blue foot, results in a blue baby. Next slide. So why do we do somatic testing? So your doctor will often say, we're sending off some genetic testing, we're sending off moleculars, and then we'll be able to develop a plan of how we want to proceed. So somatic testing, which is genetic testing on a tumor, can help with the defining of that tumor type. It can actually help in making a diagnosis. It can also help define prognosis. So there are certain changes in a tumor that might tell us that this is a favorable prognosis versus a poor prognosis. And then it can also tell us, help us to determine what a specific treatment plan. Is this an aggressive tumor? Do we want to do upfront chemo? Do we want to do remove the tumor first? So it can also help lay down the foundation of how we want to proceed. And very importantly, it can also tell us certain types of medication or chemotherapeutic agents we want to use. Does this tumor have a specific gene change in a particular gene that we can target with a particular chemotherapeutic agent? And it can also sometimes identify germline candidates. And what I mean by that is everything in our genetic makeup, everything in your body is going to be in that tumor. But everything in that tumor is not going to necessarily be in the body. So if let's say a doctor says, hey, I found a change in a gene, the WT1 gene, I found a change in this gene in the tumor, but I don't know if it's just in the tumor or is it also all in the rest of the body. They'll say, can you test this patient for a germline change, meaning we want to know if it's not just in the tumor, but is it also throughout the cells of the body? And that can help guide medical management. Next slide. And genetics and inherited are actually two very different words. Genetics, obviously, traits, for example, like hair color and eye color, can be inherited, and everything that's inherited is actually genetic, but everything that's genetic is not necessarily inherited. So someone can be the first person in the family to have a new gene change and have let's say a Wilms tumor predisposition syndrome, and that's entirely new to that individual, but that doesn't necessarily mean that mom had that gene change or dad had that gene change. And it's very likely that sister and brother also don't have that gene change. So something can be genetic without being inherited. Next slide. So why should we do genetic testing? Why should you come see me and for germline genetic testing? Well, we know that about 10 to 20%, probably even more, of childhood cancers are due to some underlying genetic cause. 70 to 80% or 10 to 20%, sorry, 70 to 80, maybe 90% are due to just random acts and just happen by chance alone. But if someone has a predisposition and found to have a change in a gene that puts them at risk for Wilms tumor, then they might also be at increased risk for other things. So knowing this information will allow us to screen people proactively for the things for which we are at greatest risk, our children are at greatest risk, so that we're identifying things at an early stage, we're maximizing outcomes and minimizing pain and suffering. It might also tell us that there's a genetic change not only in, let's say, our child, but in other family members. And so those other family members might want to have testing, and they might also want to or benefit from surveillance. And sometimes knowing we have a specific syndrome can actually also help us determine certain chemotherapeutic agents in certain cases. So how do we go about doing genetic testing? Because a lot of people say, I'm here for the Wilms tumor genetic test, but it's really not just one test, and it's based on a lot of different factors. So we can do single gene testing where we're reading the genes letter by letter to see if we can find any changes. And we do that if we have a high suspicion that we're just dealing with one particular condition. Or if we're doing, let's say, what we call cascade testing, where we're testing a family member for a known gene change, we're only going to look at that gene change in one gene. But we can also look at many genes at the same time. That's something we refer to as gene panel testing. And sometimes when we do gene testing, when we do panel testing with a lot of other testing, and we don't find anything, but we still have a strong suspicion that there's something going on, we can do something called exome sequencing or genome sequencing, where we're casting a much wider net. We are looking for changes throughout the genetic makeup to help us determine if something's going on. There's also some type of testing known as methylation testing or studies. And there are these things throughout our genetic makeup called methyl groups. You can think of them very much like a light switch. They're either on or off. They tell the genes to be on or to be turned off. And sometimes these light switches are on when they're not supposed to be or off when they're not supposed to be. So we can do this testing to see if these light switches are in the correct position. I can also do testing on our chromosomes, like the picture I showed you in the beginning. Sometimes chromosomes can be broken, they can be rearranged, they can be stuck to the wrong, like attached to a different chromosome. Sometimes they have tiny little deletions or duplications of genetic material, so we can do specialized testing for that. And of course, as I've already described, we can do somatic testing. We're doing genetic testing on the tumor that, again, can sometimes give us clues as to what's going on in the individual from a syndrome perspective. Next slide. Okay, so sometimes people come and ask, I don't understand. I carry a change in a cancer gene and I've never been affected, but my child has that same gene change and is affected. They've developed a tumor. So why is that? I also sometimes get the question of why does this happen very early versus very late? Why does someone develop a tumor early in life versus late in life? And this can all be boiled down to something called a two-hit hypothesis. So we all have cancer genes. So you can imagine in the cell of a body, someone in the general population, you have two copies of a cancer gene, and you're kind of walking through life and you acquire a change in one copy. And if you have at least one functioning copy, you're in good shape. You're not going to develop a tumor. But if you go through life, proceed through life, and you acquire an alteration or a second hit in that second copy, then there's no longer a functioning copy of that gene in the cell, which can be the tipping of the scales which can result in the development of a tumor. And oftentimes we see this in the general population, not in relationship to, let's say, a particular syndrome. And let's say someone, for example, who has breast cancer at 80 years old. They had their entire lives to acquire these two different genetic changes in the same gene, and it took time, right? So that's why something might develop later in life. Now, when you're born with an alteration in one copy and you only need a hit in the second copy in order to tip those scales to develop a tumor, that is going to happen earlier on in life. So you might develop, let's say, a Wilms tumor within the first year of life versus perhaps at like 10 years of age. So that's why certain people develop things earlier if they have a predisposition. It also can tell us why, so long as you have one functioning copy, why one person might develop a tumor, might not develop a tumor, where if you have an alteration in both copies, you would develop a tumor. Next slide. Okay, so what are some red flags that I use and others use to determine whether someone might have a genetic syndrome that put their child at risk to develop a Wilms tumor? One is family history. Do we see generation after generation a family history of Wilms tumor, or even cancer, really clusters of different types of cancers that tend to go together on one side of the family? That would be a red flag. Another red flag would be someone who developed bilateral Wilms tumors, so tumors in both kidneys, or multiple tumors in the same kidney, which we refer to as multifocal disease. That would also be a red flag that something might be going on. We can look under the microscope, and there are certain histology under the microscope that might be an indicator. And as I've previously discussed, age. Are we developing something super early in life, earlier than the general population? Next slide. And there are also certain types of clinical features that we might see in a person that we look for when they come for an evaluation. For example, someone that has Beckwith-Wiedemann syndrome might present that they are bigger than they should be, or bigger than average. They might have a larger tongue. They could have something called hemihypertrophy, where one limb or one part of the body is bigger than the other. They might have different differences in, like, let's say, ear creases or ear structure. Those are all some clinical findings. In the condition that Kelly started out talking about with WAGR syndrome, those individuals might not, or usually do not, have the colored portion of the eye, and that would also be a clinical indicator that we need to dig a little bit deeper. Next slide. So how can doctors decide who should have genetic testing, counseling and testing, and who shouldn't? Well, we know that people who have a bilateral disease, a Wilms tumor, so in both kidneys, or you have multiple kidney tumors in one kidney, or you have something called multiple nephrogenic rests in a kidney, those are all indicators where a doctor should refer for genetic counseling and testing. But what about those other individuals that have one tumor in one kidney? How do we know whether or not to test those? And again, we have to look at are there any clinical findings? If that the answer is yes, then we would need to refer. Is there certain pathology or family history that is concerning? Then we would need to refer. If a person has one tumor in one kidney and absolutely nothing else of concern, the chance of us finding something is going to be really, really low. We can still have genetic testing, but the question then becomes whether or not insurance will pay for it. Next slide. There are about 25 or more different conditions that I'm not going to go into today, but each of them is a little bit different, and we may or may not require varying types of testing. Next slide. Next slide. And next slide. All right, so what type of testing exists? Well, as I kind of mentioned before, we can do Wilms tumor cancer gene panel testing, and doing it, it kind of varies from lab to lab and what's included in that panel of genes. But we can do that type of testing on a cheek swab, so we get DNA from cheek cells. We can do it on blood extracted from fibroblasts, and we're basically reading the gene letter by letter. We can do that methylation testing on blood, where we're looking at those little light switches to see if it's on or off. That's a common test we use for Beckwith-Wiedemann syndrome. We can do chromosomes. We're checking the chromosomes to make sure that they're appropriate structures and rearrange if there are any rearrangements. Again, we can do that on blood. We can do it on cheek swab, extracted DNA. Obviously, somatic tumor testing, we're looking at the tumor itself, and we can do the same types of testing on that tumor as previously described, but just in the tumor as opposed to blood or cheek swab. Nowadays, a lot of institutions are now moving towards something called paired germline somatic testing up front. So they're looking at the tumor and doing genetic testing at the same time as they're looking at to see if there's any sort of germline or change in a gene in the entire body. And again, a lot of times whole exome, a whole genome sequencing is used when we still suspect something, but nothing has come back positive as of yet. It's also used for gene discovery, and something that is now in the research phase, which I think is really going to revolutionize the way we approach genetic testing, is something called long-read sequencing. It's a new technology that basically looks at all of the above. It looks at the different gene, little letters of the gene, the coding regions of the gene. It looks like the regions between the coding regions of the genes. It looks at DNA, RNA. It does methylation studies. You can tell if the gene, if there are multiple gene changes, if that's in the same gene copy or two different gene copies. So lots of different tests that we have in our toolbox. Next slide. So we can do genetic testing, and that basically is, again, taking that DNA sample to determine if you have a syndrome, and you can get a positive result, a negative result, or what's called a variant of unclear significance, our dreaded one, which we find a change and we don't know exactly what it means. Not all gene changes are bad changes. We just sometimes don't have enough data to interpret it. Whereas screening is, once we've made that diagnosis, if the person is positive, we're going to put a plan together to screen that individual for the tumors they're at risk for. So that could involve blood, that could involve radiology studies. So that's really kind of the difference between screening versus genetic testing. Next slide. So where can you get genetic counseling and testing? Well, first and foremost, your doctor can refer you, and a lot of times that can be either in person or via telemed. Your pediatrician can refer you, or if other family members, your other children, your pediatrician can refer you for genetic counseling and testing. And then you can go onto the website known as National Society of Genetic Counselors, and you can plug in your information. You can plug in, like, find a genetic counselor, list where you live or your zip code, and as well as what you're looking for. You need prenatal, you need cancer, and they will it'll produce a list of people who you can contact. Next slide. And of course, you can always ask your provider to refer you. Even if your doctor says, I don't really think it's genetic, I don't really think you need to be seen by anyone, you can always ask and they can always refer. And that's all I have to say. Thank you so much again for having me. I've been more than happy to answer any questions that any of you might have.
Thank you so much. Joyce, there are some questions in the chat. Let's see, we do have time to answer a few. First question is, my daughter had Wilms tumor at age 4. She is now 9. We were told yesterday she is completely done with follow-up scans. However, we recently discovered that along with her, 4 out of 6 of my kids, also myself, have the CDC 20 variant. I never had cancer and my 10-year-old never had cancer. Trying to figure out what to think about next.
That's a very good question. So that's a new one and a new gene, relatively new gene, that we can add to that long list. And one being, if there's concern that this is a predisposition syndrome, then actually screening for additional tumors would continue until age 7. So that could potentially modify the screening regimen that your child that's affected versus perhaps those that have not been affected might need. And so I would revisit that with your doctor or your child's doctor. And I think, as I described before, not every gene change is necessarily fully what we call penetrant, meaning like you can have a gene change and never develop a tumor. And that might be because you didn't acquire a second hit to that second copy of that same gene, whereas a child might have acquired a second hit to that second copy, and therefore that kind of tipped the scales that resulted in a tumor.
Let's see, a second part to that question is, are there any research labs currently studying CDC 20 function that we could connect with?
Off the top of my head, I can't list a lab, but there is something called clinicaltrials.gov, where it's sponsored by the NIH, and you can go into that and you can type in what you're looking for, and it'll pull up all the studies throughout really the world that have testing that's being funded by the NIH. So that's one way you can see if it's being studied in different places.
That's great. Let's see, another question. Is there much research on blastemal cell dominant Wilms on initial diagnosis and relapse diagnosis? And how does that change prognosis?
I'm going to have to defer that to a doctor. It's a little bit beyond my scope of practice, unfortunately.
Let's see. If nothing is found during genetic testing for Wilms, what chance, if any, would a sibling have for the same cancer?
That's a really, really great question. I don't know that I have a specific risk figure for you. It would really depend on what else is going on. So is it just kind of going through that laundry list of different things that I look for, or that doctors look for. Are there other clinical findings? Is there any sort of developmental delay? Is there autism? Is there any sort of physical structural differences? Is there any sort of consanguinity or related mothers and dads, or even cousins that are related? We have to go through all of those different check boxes to see if there might be something else going on. And if we go through all those check boxes and there's still a concern that there's something going on, then what I would actually recommend, or what I do for my families, is refer them to various research studies. There are research studies for unknown or the undiagnosed disease programs of the world, where they collect people to participate in research to try and do basically gene discovery to find an answer for those families. And if we are able to find the answers for those families, then maybe we can do targeted testing for those other family members to see if they're at risk. But a lot of times when we don't know, and there's still a strong suspicion, like for example, I had a mom who had bilateral Wilms tumor when she was a kid, and it was bilateral, so there was a very strong suspicion that there was something going on. And she had 3 kids, and we worked her up, and we did test after test after test, and actually over a number of different years, as our understanding of Wilms tumor progressed. And it all came back negative. So how are we left? And in that situation, the oncologist chose to screen her children according to various Wilms tumor screening guidelines, which are technically every 3 months until age 7 with ultrasound.
Very helpful. Let's see. Is there additional testing that you would recommend for a child with known BWS, Beckwith-Wiedemann syndrome, GOM at IC1, who keeps developing subsequent tumors in the same kidney?
Unfortunately, it's hard to. The question is whether or not those are new primaries versus recurrences of the same tumor, right? And so I think you have your answer in terms of what's the underlying cause of those tumors. The question is it keep on coming back? And one thing that what I think about when you have a multiple recurrent tumor is doing some somatic testing if it hasn't already been done. What's going on in that tumor genetically, and is there a chemotherapeutic agent that can target a particular gene change that might be present that might be more effective?
Also very helpful. My daughter is stage 1, favorable histology Wilms tumor with 1Q gain. We were told she does not need genetic testing. Why would we not? Is there a reason you would advise against it?
So if she has one tumor in one kidney, absolutely nothing else going on clinically. And sometimes it does take a very, careful examination, looking for those teeny tiny ear creases, looking at the pregnancy history. Was this an IVF pregnancy? Sometimes there is a slightly elevated risk with IVF pregnancy to have Beckwith-Wiedemann syndrome, for example. Is there anything else going on that's just ever so subtle? If the answer is no, then there's a very low chance that we would actually find something if we actually were able to do the testing. And I say able because this testing is not inexpensive, and we have to get pre-approval by insurance companies to do it. And if we have to justify the reasoning, and if I only have a patient that has a kidney and one tumor and no other problems, whether it be in the patient or their family, there's a chance that it could be denied. It doesn't mean that we couldn't try just to rule it out. So that's always a possibility. Even if the doctor thinks that they don't think that it's necessary, you can say, well, I'd like to speak with a genetic counselor, please. Can you please refer me? That is your right.
Terrific. Let's see. I don't think we have any more questions from the audience. However, just a few general questions. What would you say are the main reasons a family would choose somatic testing versus germline testing?
So most of the time, the somatic testing is something that's decided with by the doctor. So it often is done well before I am ever introduced to the person. Sometimes when I meet the person and I have a strong suspicion, let's say, for example, that this person has Beckwith-Wiedemann syndrome, and I do testing to see if they have Beckwith-Wiedemann syndrome, and everything that I do comes back and is negative. I might then want to do some somatic testing to say, hey, let's apply all those same techniques that I did to see if they have like a germline version of Beckwith-Wiedemann syndrome. Let's apply all that same testing to the tumor. Let's do some methylation studies. Let's do some gene sequencing to see if there's something else going on. Because some people can have what we refer to as a mosaic form of a condition, where that gene change, like I said, might have been acquired during, let's say, embryonal development. And so that gene change or that difference is not in all the cells of the body, but it could be in a big portion of the cells of the body or the majority of the cells of the body. And that person has something called a mosaic form of for example, Beckwith-Wiedemann syndrome. So that might be one situation where I might want to do somatic testing.
Thank you. Well, I don't think we have much more time for any more questions. If you look in the chat, you'll see that the NIH resource can be found on the Elevate website, elevatechildhoodcancer.com. If you click on the reliable information button, you'll have access to this and other resources that could be really helpful for the things that have been discussed today. And Joyce, thank you again for your knowledge and your expertise. It is so appreciated. Thanks so much.